Well, good afternoon, and I hope you're having a good day. I was asked to give this talk in China, and I was there in September. So my talk had to be translated, so I spoke. There's a Chinese in China, no one speaks English, very few people. So I had the opportunity to visit the Great Wall, and it's very impressive. It's 1,000 miles long, and up here, so the Great Wall is going up. We were somewhere here, and someone has put here in praise of Mao, and no one can reach this spot. It's like way up on the mountain. So I had a lot of fun. So let's talk about this problem that is rather vexing, because we often get a call from the dialysis unit saying, Dr. Abreo, Mr. So-and-so's arm is very, very swollen, and we can put our needles in the vascular access, but it's very swollen and the patient is very upset. And our dialysis patients usually don't like to come for procedures, but patients always show up because the arm is very, very swollen. And here are two examples. Here is a lady. You can see this arm is not swollen, but this arm is very swollen. And you can see she has either a graft or a fistula in this arm. And here's another gentleman. He had a fistula here, and this arm is very swollen compared to this. And so when the arm is swollen, we can say the problem has to be somewhere in the draining veins. Okay? Typically in the veins of the chest, the veins are called the central veins. These are large veins, thick-walled, very elastic, and they are in the rib cage. They're very difficult to approach, especially surgically. So up in the chest, you have the superior vena cava, so the problem could be here. It could be in the brachiocephalic vein, or what's called the innominate vein in the past, or it can be in the subclavian vein. Okay. We also put grafts in the thigh, and sometimes the leg gets swollen, and then you have to think about the inferior vena cava, the iliac veins. These are the central veins here. So the patient typically will present, as I said, progressive edema in the arm with a fistula or graft with pain and peripheral ulceration. And if the edema is bilateral, arm, so both arms, face and breast, then the lesion is in the superior vena cava. If it is unilateral arm, face and breast, it's in the brachiocephalic vein. And if it's only in the arm, it's the subclavian vein. So you can just make a diagnosis of where your lesion is going to be just by a thorough exam, examining the arm, the face, and the chest. And you will find, even if you look on the chest, you will find venous collateral circulation across the chest wall. And the dialysis unit may call and say, when there are high pressures, that means when they take the needles out, the patient has to sit there for a long time because the needle sites bleed, because there's high pressure in the vascular circuit. Or there are aneurysms in the fistula, or there is inadequate dialysis. Because whenever we think of vascular access, most of us think only of the part where the needles are placed, but it's actually a circuit which starts from the heart, goes down the big veins of the heart, down the brachial vein, and then up the brachial artery, and then into the radial, and then up the venous all the way back to the central veins and back to the heart. So problems can be anywhere in that circuit. So here is an example of a patient here. You can see the dilated veins on the chest, and here too on the left this patient has dilated, and only the arm is swollen. This lady's face is swollen, and then both arms are swollen. So here you can say the problem is in the superior vena cava. Here it's probably in the subclavian. So when we do we use the word fistulogram when there's a fistula and there's a graft. So that's the easiest way to access. We just enter the fistula and graft, shoot some contrast, and often we'll either find a very tight stenosis here or complete occlusion of the central vein. Here in this case, the subclavian vein. Now the true incidence and prevalence of central vein stenosis in end-stage renal disease patients is truly unknown, because the only way we know that someone has it is when an access is placed by a surgeon. Sometimes the access is placed and within 24 hours the arm is swollen. At other times the swelling may come a few months later. But there must be a silent central vein stenosis that's there, but it's never provoked. So there's a high, but once the swelling occurs in the arm, you can be very sure that you have central vein stenosis. Now, why do we have central vein stenosis in these dialysis patients? Because in reality, the central vein should not have stenosis in most patients. And in the non-dialysis patients here, unrelated to intravascular device, it's quite rare. But in the dialysis patient, it's very common. And the cause of this is tunnel dialysis catheters. Unfortunately, in the United States, for complex reasons, almost 80% of patients start dialysis with a tunnel catheter, which is really bad because that's not how it is in other countries. And you can blame, you can blame the doctors, you can blame the patients, you can blame the payment issues and so on, but 80% start with the central. And if you see here, with a tunnel dialysis catheter, about a third of those patients will develop central vein stenosis. Central vein stenosis also seen with non-tunnel catheters. So it could be a triple lumen catheter, an all-doll catheter just placed for a few days and then removed. It can also occur with peripherally inserted central catheters, PICC lines. So the PICC lines and also with port catheters, you can see central vein stenosis. In this study, about 150 patients had PICCs placed, and then they went and did venograms, and they found 7% of patients had, and other central venous catheters. The other one is cardiac rhythm devices. Cardiac rhythm devices are typically, the leads are placed in the subclavian vein. The cardiologist cannot place them in the internal jugular veins, so they put them in the subclavian veins, and they have a high incidence of stenosis. Okay. Now, unrelated, you can see it with idiopathic extrinsic compression of the vein, fibrosing mediastinitis, retroperitoneal fibrosis, post-radiation therapy. So as I told you, 80% of end-stage renal patients start dialysis with central venous catheter. And the number of catheters and the duration of catheter placement plays a role. When I say duration, there was a big push to put fistulas I would say about 10 years ago. It was called the Fistula First program. So in the zeal to put more fistulas, what was happening is the surgical skills and the patient comorbidities have a big influence of how long it takes for a fistula to mature. So surgeons were just placing these fistulas and they never matured. So patients would, they would examine, oh, there's a fistula. And the tunnel catheter was placed for many months. So imagine a tunnel catheter for 6 months in a patient. It's going to cause stenosis. Then there were other patients who the tunnel catheter will not work, or repeated infections, you keep on changing. So you either change the site or you put a new tunnel catheter in the same location. So number and duration of central venous catheters had a big bearing on the presence of stenosis. And then location of the central venous catheter also is important. There's more stenosis in subclavian catheters than in internal jugular vein catheters. And there's more stenosis with the left internal jugular vein catheters compared to the right internal jugular vein catheter. So here's an example showing you there's a catheter here, a tunnel catheter in the right internal jugular vein, and notice here right in the innominate or right brachiocephalic vein area there is a stenosis, and you can see the collaterals develop. Now why left more than right? Okay. When you place the central venous catheter on the right, it just goes straight down. You know, it's in the IJ, it goes down. On the left side, it makes three sharp angles. The first angle is when the internal jugular vein meets the subclavian vein, okay, to form the brachiocephalic vein. So the first turn. Then there's a second turn which you don't see on X-ray, plain X-ray. That's an anterior turn across the mediastinal blood vessels, aortic arch, okay, and that's on this transverse plane. You can see that second turn. And the third turn is when the brachiocephalic vein goes into the superior vena cava. That's turn number 3. So when you take out a left IJ catheter and you place it on the table, you will actually see these turns. You know, a catheter has been there for so long, it will show you the 3 turns. In addition, there's an ultrasound study showing that the left internal jugular vein cross section is much smaller than the right internal jugular vein. So, on the left side you have a longer catheter, many more turns, and the left IJ is smaller in diameter, much higher incidence of stenosis on the left side compared to the right. So if you have a choice, go on the right side. Actually, placement also is easy on the right. For any central, even for a temporary device. So sometimes we see patients like this, tunnel catheter on the right and a pacemaker on the left, okay. So this patient, unfortunately, you know, is going to have bilateral stenosis, and if you put an access on either arm, patients are going to have swelling. And if you notice, they already has got these collaterals, you can see them on the chest. You will notice that the cardiologists prefer to place pacemakers on the left, and the surgeons prefer to place vascular access on the left because most people are right-handed. So if the surgeon doesn't do a thorough exam, or if you as a physician don't tell them, they will just put an access on the left, and the next thing you know, you have a swollen arm, and the surgeon doesn't want to get rid of that access. He took so much trouble, you know. So this is a common thing that happens. Now here's the cardiac rhythm devices. Okay, so here's a pacemaker. This is on the right side, and there's a stenosis here. So the issue here is how did I went to? Okay. All right. And so you will see a stenosis here. Now let's go to the pathophysiology. So why does this stenosis occur? All right. The first thing is when you are inserting the catheter, you're going to puncture the vein. So you're already traumatizing the vein when you are placing the catheter. The second thing is the catheter is, even when the patient is sitting still, the catheter is moving. It's moving with the heart rhythm, it's moving with respirations, it's moving with a change in the position of the neck, and it's moving when the person is lying down to sitting up. Especially if you have an obese patient, the catheter will move several centimeters when an obese patient sits up, you know, and the fat kind of drops, the catheter moves. So this constant movement is going to make the catheter hit the endothelial wall. Constant hitting of the endothelial wall is going to cause inflammation and thrombus formation. Eventually, sometimes the catheter actually gets stuck to the wall, fibrin sheath forms around the catheter, and then the vein itself is traumatized. You will get intimal hyperplasia and fibrous tissue formation, and you will get a stenosis. So when you take that catheter out, you have a stenosis there. So having said that, let's look at some of the treatment options. The first one is angioplasty and stent. Watch and wait for mild arm swelling to go down. ligate the vascular access and place one in the other arm, and surgical intervention. Okay. So we'll discuss each one. So everyone, for the last 3 decades, there's a lot of literature on angioplasty. Okay. It seems to be like the main accepted primary treatment for a swollen arm in the setting of a vascular access. But the literature is, there's lots of literature, but small numbers of patients. Most of it is retrospective. Other lesions are mixed. So in general, the primary patency for angioplasty is 29 to 30%. So what it's telling you is that angioplasty does pretty much the same thing that the catheter does. It opens the vein, but it causes endothelial damage. So the stenosis comes back. So you immediately feel success, and the patient is so happy because the swollen arm is gone, but you know that in a few months it's going to be back. Okay. So that's the problem with angioplasty. Now, there is a study going on with a drug-eluting balloon. I think Bard has a study, a balloon called Lutonix, and some early data seems to suggest that the stenosis recurrence is delayed. With the it's a paclitaxel eluting balloon. Paclitaxel is a chemotherapeutic drug. So here's the example from our files. Here's the stenosis, here's the balloon, here, nice, and you're pleased. Success rate is about 80 to 90%. Once you get the wire across, it's going to open, But if you don't follow up, you're very pleased, but the nephrologist will be sending the patient to you very soon. And you can do that also with a pacemaker wire. Now the problem with the pacemaker is you're going to put the balloon across the pacemaker wire. So there's now some risk. You open the balloon, you could dislodge the pacemaker, and your patient can go into an arrhythmia and potentially die on the table. You could crack the pacemaker wire, if you go to very high pressures, all right? So those are the issues, and there are some papers like this in the literature. We ourselves, I have opened balloons and not had any problems, but not many patients, just a few patients. Here you have 13 patients, 14 interventions, 100% success, and they went up to 120 days. That's 4 months, just 4 months, and they found like 50%, patency. So most patients by 6 months, half the patients have re-stenosed, and a couple of patients had stents. Stents create one more problem, because now you have jailed the wire. So you have a wire between the stent and the wall of the vein. So if you have an infection, okay, then it's a horror story, because you have got that wire trapped. Okay, so those are the things that you have to keep in mind when we have placed some stents across these lesions. Okay, so angioplasty and stent. As I told you, a patient comes back, keeps coming back, so you may consider placing a stent with a hope that the restenosis will be delayed. On the other hand, you may have an elastic stenosis. So you open the balloon, you collapse it, and the stenosis just comes right back. The wall is very elastic, and you see more of this in the central veins, much more than in the peripheral veins. So you decide to place a stent, and here is patient, here there's a collateral vein, here's a stenosis, and here is a stent across the stenosis. Looks very nice, the collateral vein is gone, you're very pleased, okay? But again, the problem is that if you wait long enough, the stenosis will come back. Here is a patient who we had a left-sided access. They tried to put the wire across the stenosis here, it wouldn't go. So Dr. Sequeira went through the femoral vein, and the wire went across that lesion when he went from the femoral vein, okay? And he was able to then angioplasty, all right? and he ended up actually placing a stent. But he came down from the femoral and did it. But this is the problem with the stent. There is intra-stent stenosis. So the problem is not gone away, but the hope is that it will be delayed, see. And now, when the early literature is using bare metal stents, then the stents have now changed to nitinol stents. These are more delicate, and when they come in contact with body temperature, they have a memory. And now the latest stents are coated stents, coated with PTFE. The argument is that when you have a PTFE coated stent, intimal hyperplasia that occurs does not occur because the fibroblasts, and the media, the muscular tissue, can't penetrate the PTFE. Okay, that because it's coated, it's covered. Okay, so there's less chance of stenosis. So that is, there's a pacemaker on this side, there's a stent on this side, okay. So if you are able to, do a good job, look how the patient is so pleased. The superior vena cava stenosis, as I don't know whether they place a stent or they just did an angioplasty, patient is very pleased with the result. Now, there is a old paper here in Kidney International where they did 47 angioplasties in 30 patients, and the point here is some of the lesions are fibrotic. So some stenotic lesions are fibrotic, and those, when you open the balloon, they stay open, okay. But others are elastic, so even when you open, they collapse. Now fibrotic lesions, when you angioplasty them, they tend to stay open, at least in this paper, 7.6 months. The elastic lesions, the patients came back very early. Now, when you put a stent, but they did that only in 10 patients, it's the opposite. The elastic lesions lasted longer when you put a stent, while the fibrotic lesions came back earlier. So the fibrotic lesions are probably very active, very luxuriant. The fibrous tissue comes in very fast. So the thing here is, whether you have a stent or not, if you look at these two Kaplan-Meier curves, they superimpose on each other. So these patients first had a PTA, and then when the lesion was not responding to the PTA, they placed a stent. But the intra-stent stenosis recurrence is almost the same as the angioplasty. So my philosophy is to try and go with angioplasty as far as you can, but when the lesions are coming back very quickly, then place a stent. It may not be a good idea just to go ahead and place a stent, even when the stenosis has gone away, the first round. Just wait, angioplasty a few times, and then place the stent. And if possible, place a covered stent. The problem with the covered stents is you need a very large sheath size, like 12 French sheath, to put some of these covered stents. So, what about surgery? The stenosis is in the rib cage, so you have to crack the chest open. So that's major surgery, So you have this option. Angioplasty is not working. Okay, should I just ligate the access and go to the other arm, or go to the leg, or should I ask a cardiothoracic surgeon to open the chest? It has major surgery. So most surgeons are reluctant to do this kind of surgery. They may probably do it as a last resort. All access sites have been used up, and this is the last vascular access the patient has. So they can go and do a patch angioplasty of the vein, or they can do these procedures such as subclavian to internal jugular vein bypass, jugular to right atrial bypass, subclavian to innominate bypass. Okay, and here's an example. Okay, so you have a stenosis here in the subclavian vein. the internal jugular vein is open here. So the surgeon takes this and he anastomoses it here to, it looks like, to the axillary vein, you know. So yes, this is now the internal jugular vein has become large, okay, and it's draining, so it's bypassing this very tight stenosis, okay. So that's the kind of surgery. And there was one paper here, I think it's from New Orleans, 13 surgery, 13 for angioplasty. Surgery seemed to do better, but when they did the analysis, the p-value was not significant. But in generally, surgery would do better than these devices. Now there's a device called the HERO device. Okay, the HERO device is specific for patients who have central vein stenosis. Okay, so say your patient has, everything is gone, all sites are gone, cannot put an access anywhere. Okay, and there's only one catheter left in the neck. What do you do? So this this access has a combination. It's got, part of it is like a graft and part of it is like a catheter. Okay, so from here to here it's a graft, from here to here it's a catheter, but it's all under the skin. This is made up of PTFE and this is made up of silicone. Okay, so this is one of Dr. Tan's cases. All right, he has now put this, what you are seeing here is the silicone part. Okay, and it's in the internal jugular vein. So basically what they do is they'll put the wire into a tunnel catheter, take the tunnel catheter out and put this new catheter and then hook it up to a PTFE graft, which is now anastomosed to the brachial artery. So now it feels just like a graft, right? And here's another example where he had right IJ occlusion, bilateral subclavian vein occlusion, and only left IJ is patent. So here is, actually there is also a pacemaker here. There's a pacemaker here, complete occlusion here, okay, and he has put the wire from the left IJ, okay, and now he has put a PTFE. So now you have this silicone catheter and he has got the pacemaker wires and then the vein ball, okay, and the final product is here. You can see the catheter here. Okay, so that's called the HERO graft. So now primary patency of angioplasty, stents and surgery, most of the PTA papers suggest that at 12 months only about 30% max, 20 to 30%, okay. Whereas with stent, I think some of the papers suggest better outcomes, and with surgery the outcomes are the best, but the numbers are very few, and as I told you, the morbidity is very high. Sometimes the best thing to do, sometimes patients will say, Dr. Abreo, don't do anything. If you can't do, just leave it. They're accessing my fistula. I don't care about the swelling. So you tell the patient, keep your arm raised, you know, and with time, collaterals will develop and the arm swelling will become less. But that takes a little time, you know. Now this lady is very interesting. She had a swollen arm, okay, but we were using her access. After some time, the swelling in the arm has disappeared, but she has this swelling. And I don't know, it may be the chronic edema that she had, she has this. And she has complete occlusion of the central veins, complete occlusion. And now this is almost, I would say, 7-8 years. This fistula is working. And she's on dialysis and she's doing very well. So we have just left her alone. Periodically someone will see the swelling and they'll refer her to the surgeons and I cancel the, so no, just leave her alone. Okay. So just a conservative approach may be fine. Now, sometimes when interventionalists go into a graft or a fistula and they shoot some contrast, okay, the arm is not swollen, but suddenly they will see some central vein stenosis. And it's a great temptation in a balloon, all right? You say, oh, I can see a 70% stenosis in the right brachiocephalic vein. I'm going to put a balloon. Don't do that. Of course, there's not extensive literature, but see, this is a asymptomatic stenosis, means no swelling, okay, of the arm, no problems with the access. 26 patients were treated and 12 were not treated. This is a retrospective review depending on the radiologist who was doing the procedure. Before treatment, 74% stenosis. After treatment, 40% stenosis. Okay? Here they didn't treat. But see what happened. The progression of the stenosis was much more in this group. Because what does angioplasty do? It just ruptures the endothelium, you know. It's a very drastic procedure, right? So the stenosis got worse in these patients. So my philosophy is, if you see a stenosis, the access is working fine, there's no arm swelling, leave it alone. You know, don't open a balloon. Now, arm swelling is a different story. Then you have to approach it in the way I showed you. So, how can you prevent this arm swelling? Of course, the first thing is we have to educate nephrologists, you know, we have to educate surgeons so that they put an access early when patients are in the clinic, so that they don't get tunnel catheters. Okay. Then avoid placement of vascular access on the ipsilateral side of a cardiac rhythm device. So surgeons have to be told, don't put a vascular access whenever you on the side of a pacemaker. Okay. Investigate the presence of central vein stenosis in patients who have prior long-term or multiple central venous catheters. So if someone has been dialyzing with multiple catheters for a year, that patient needs a venogram. Ultrasound is not that good in detecting central stenosis unless you've got a super duper ultrasonographer, because the chest wall, you know, all the bones here, and especially in obese patients, very difficult to visualize the central veins. So it's best to do a venogram, and then the side that is open, you put the vascular access. Okay. So that we get a number of consults for this from the vascular surgeons. So a good vascular surgeon will do that. So my take-home points are, so surgeons should avoid construction of a permanent access on the side of central vein stenosis. And the way he can detect it is by doing a venogram. Angioplasty with or without stent is a treatment of choice. Recurrence of central vein stenosis is common after angioplasty and may require stent placement. In patients with mild swelling, watchful waiting is the best approach. Ligating the access is best if unable to cross the stenosis with a guide wire. So if the other arm is free, maybe just tying it and losing the access may be the one approach. Surgery is rarely done because of the high risk in ESRD patients. And do not angioplasty central vein stenosis if there is no arm swelling. Thank you.
This is a very important topic. This is a main important topic. These people that have venous hemodialysis, their life depends on the vacancy of these veins. You know, and as you realize, we have a limited number of them. So whatever Dr. Abreo has talked to us today, and the best, I would say, focusing on this problem, because it's a chronic issue, you know, and if you're not careful, and I think it's very, I mean, he has a tremendous experience on this. I think that
there are only 6 sites. The dialysis patient, only 6. 1, 2, 3, 4, 5, 6.
Yeah.
Only 6 places you can put an access.
Yeah. Also, it's interesting that, you know, the thick lines, that I'm very fond of thick lines in general. You know, the 7% is not so bad.
No, it's not bad.
You know, because the thick lines benefit for patients, especially patients that are talking renal.
Correct.
Insufficiency.
Correct.
You know, it's wonderful. Always think about thick lines instead of having puncturing this.
Yeah.
That's what
for CKD patients, PICC lines are not good for 2 reasons. The peripheral veins are used up because you're going through a peripheral vein,
Yeah.
and that's where we put the access. And in a small number of cases, you may get central vein stenosis, but more problem is the peripheral veins. You're using up these arm veins. So that's for CKD patients. But for other patients, it's fine.
So, that you're getting more, there's a national trend switching into the fistulas, making more fistulas.
There has been a push to put more fistulas, and we went from 25% fistulas to almost, at least here in Shreveport, almost 50 to 53%. The national goal is 66%, but we are not achieving that goal because of many factors. You know, surgical skill, obese patients, comorbidities, lots of diabetes, and so on. So we are not reaching that goal. However, there's been a downside to fistula first, in that people were putting these fistulas and they were not maturing, so they had tunnel catheters placed for too long. So now the emphasis is put a fistula but try to get the catheter out. If the fistula doesn't mature within a couple of months, put something else, put a graft, but get the catheter out. Because people die with these catheters. There's very high infection and sepsis and death, with tunnel catheters. Yes, it's recommended to put the fistula, in the clinic before dialysis is started, and you can do a fistulogram. We do fistulogram with 10 mLs of contrast. With 10 milliliters of contrast, we can do a decent fistulogram. We get 5 shots. Boom, boom, boom.
Are you familiar with the difference technique between a fistula and a graft? Why don't we go over what a graft is?
A fistula is like, you have heard of a traumatic fistula. When you're putting a central line, accidentally you may pierce the artery, go through the vein and pierce the artery, and now you got an abnormal connection between the artery and the vein, and if you put your stethoscope, you'll hear a bruit. So that's the traumatic fistula, but this is an intentional fistula where you take a vein and you connect it deliberately to the artery. So you take the cephalic vein in the upper arm, you cut the vein and you bring it to the brachial artery and you anastomose it. The whole cephalic vein now, it becomes large, the walls become thick, and it has got a bruit and a thrill, and that we call a fistula. So the fistula is completely natural in the sense that it's an unnatural thing, but it's a natural, there's no outside substance. It's your own body's tissues, right? So anytime we use the word fistula, and the fistulas have the least complications, they have the lowest infection rate, and if you have a good fistula, the survival rate is very high. Now, if you don't have good veins, the veins are very narrow or damaged, then you have to use something else instead of the vein. So you use synthetic material. I was using the word PTFE, it's polytetrafluoroethylene is that material. It's it's thin material made into a tube. You connect it to the brachial artery, say, and then you bring it over the arm and connect it to the axillary vein. So that is called an arteriovenous graft. The problem with the graft is the survival is very poor. Almost 50% of grafts are gone by 1 year. By 3 years, all your grafts are gone. So they don't last long because you develop neointimal hyperplasia in the vein where the graft is entering the vein. And there's a lot of research going on trying to overcome that. So that's the difference between a fistula and a graft. The problem is that the grafts and fistulas, infection is almost the same, but the longevity of the graft is short. But the tunnel catheter is the worst because you have this high infection rate,
Again, overall, which is the expected survival of a middle-aged person, individual, that is put into dialysis?
The survival today is very poor on dialysis. It is worse than some of like colon cancer. Our annual mortality is 20%. 20% on dialysis. and across the board, you know. But of course, if you have a very elderly patient who is like 70, 80 years, their mortality will be 70, 80%, you know, in 1 year. Whereas you have a young person, the mortality will be much lower. But if you average it, it comes to 20% per year. Yeah, it is very high. And the cardiovascular mortality for a 20-year-old or 30, between 20 and 30, cardiovascular mortality is the same as a non-dialysis 80-year-old. It is very high. So,
when we talk about Brescia, Semino, is it the same?
yeah.
The same, just
Yeah, the Brescia and Semino in 1965-70, they what they did is there's this it's called the anatomic snuff box. You have the radial artery and the cephalic vein. Semino was a surgeon. Brescia was the nephrologist. Okay, so they connected the side to side anastomosis of the cephalic vein and the radial artery. Okay, and they formed a fistula. Nowadays they don't do side to side, they do end to side. So the end of the vein to the side of the artery. But when they did that in 1965-70, there was no obesity. There was very little diabetes. So the comorbidities were very low. And the number of patients on dialysis were very few. When I came to Shreveport in '85, we had only 2 dialysis units. Total number of patients about 150. Today we have 1,500 patients in Shreveport. You see, because diabetes, obesity and diabetes, just 50% of dialysis patients are diabetic. So it's a huge problem, and Medicare is, you know, struggling because every year the cost is, the number of patients are growing, and the cost for the government is huge. It eats up almost 10% of the Medicare budget. To keep, about 600,000 patients alive, it's eating up almost 10% of the Medicare budget. You know, the Medicare budget is for what? 250, 300 million Americans. Imagine 500,000 people eating 10% of the budget, right? So it's a very expensive.
This is wonderful. I mean, this is wonderful, especially if you talk about all the aspects, about all the different types of stenosis, which is so super serious. And also the other alternative to put your friends chemo.
Yeah, there are other types of.
Hepatic,
Yeah.
very sad. Okay.
Thank you.